But we'll just discuss a few case scenarios. It is going to be interactive, right? Okay, so just feel free to chip in because I know I'm not giving you a lecture or anything. It's just to see how you would manage various scenarios during colonoscopy, right? Okay, so scenario number one, you can read it all. This is a chap, 76-year-old elderly gentleman, presents with bright red rectal bleeding. He is diabetic, has got a mitral valve replacement, so he's got a prosthetic mitral valve. He's on warfarin, right? He was also suffers from angina and has had an MI in the past. So there are comorbid factors: diabetes, mitral valve replacement, ischemic heart disease, right? And he is on treatment for all of them. In view of his comorbidity, obviously, anyone, he would try to avoid doing an invasive procedure. So they did the CT colonography on him. These are real case scenarios that we normally, right? So that showed a 3-centimeter polyp, which just Paul very elegantly demonstrated in his previous lecture. So that type of polyp. And the problem is, if the CT colonography was normal, it would have been fine. So they found a polyp there. So what do you do now? You got to do some, शैतानी का काम है, काम निकल आया आपके लिए. And this is a patient in whom you expected कि यार ये normal होगा और जान छूट जाएगी. So how do you approach this patient? And it is the sort of polyp which Paul showed you. So what do you do? Right, okay, fine, you give the preparation, okay, fine, good. Or stop the warfarin. तो ये इसमें सिर्फ जो एक बात ये है, I am uncomfortable with stopping the warfarin with mitral valve replacement. जी? हाँ. हाँ. Yeah.
Then stop warfarin 5 days before and bridge it with the heparin.
Okay, fine, fair enough. Yeah. Are you happy with that? जान छोड़ा रहे हो उसने कह दिया तो ये सब कहते हैं ठीक है हाँ that's what we will do because the problem with mitral valve is that prosthetic mitral valve is that if you stop warfarin or if your coagulation is suboptimal, it will seize. Prosthetic aortic valve does not seize, or a tissue aortic valve would not seize, right? Okay, so that's the important bit here. So we will stop the warfarin, put him on small molecular weight, low molecular weight heparin, and do not give the heparin injection on the day of the procedure, right? Okay, so that is how you would proceed. Now, just briefly, there are certain things which are high risk. You all know that from the guidelines. Atrial fibrillation associated with valvular heart disease. Atrial fibrillation on its own in a patient with hypertension is not such a high risk. But those who have got high, if you stop their warfarin, they will throw up an embolus. Mechanical valve in the mitral position, mechanical valve and previous, even if it's an aortic valve, but if they've had a previous thromboembolic event, that is a high risk. Procoagulable state, protein C, protein S deficiency is a procoagulable state, and within 3 months of a DVT-RPE. In those cases, I would be reluctant to stop the warfarin. And if you are doing a diagnostic colonoscopy, I do not routinely stop anticoagulants, right? Low risk conditions are 3 months, more than 3 months of DVT, PE, fine, you can stop it without much problem. Uncomplicated are paroxysmal non-valvular atrial fibrillation. You can take the risk. Bioprosthetic heart valve. Bioprosthetic is heart valve from pig or cow. Mechanical valve in the aortic position. They are low risk, right? Okay. Now, these are, you've probably seen all these things. The main thing is low risk procedure. If it's a diagnostic colonoscopy, diagnostic ERCP, carry on with your warfarin. We normally do not stop warfarin in these conditions, especially diagnostic colonoscopy, diagnostic OGD. You can take forceps biopsies in these cases safely, irrespective, right? High-risk procedures are conditions like ERCP with sphincterotomy, EMR, dilatation of strictures, therapy of varices. For all those, you have to stop the warfarin, and high-risk condition, you bridge it with low molecular weight, right? Okay. So that's what we do. Yeah, go on.
In the case that the patient was actively bleeding and the patient had recent history of MI, so he was prone to myocardial ischemia, secondary to
No, I don't understand. After polypectomy or before?
Before, the patient had history of bleeding per rectum, I guess. If we
Yes,
go
sir.
back to the history.
No, no, if it's not actively bleeding and he's not exsanguinating, you can,
The patient had history, we presented with bleeding per rectum.
yeah.
He was actively bleeding from that colon.
Which one? In the history?
Yes, sir. In the history, if you can go
Had
back to
rectal, presented with history of rectal bleeding means intermittent rectal bleeding,
Okay,
right?
now we
Okay.
continue.
So it's not, it's a different scenario if you got somebody with torrential bleed. That's different.
Yesterday we discussed
We
this.
just, yeah,
You have to see what is more life-threatening.
yeah.
If somebody is losing blood and that's life-threatening, then you forget about every other risk, you focus
And
on
save that, yeah.
But if it's intermittent bleeding,
That's not-
bleeding never, almost never harms you.
No.
Rectal bleeding is a very small percentage of patients where it actually harms you with serious blood loss. It's a small percentage. Majority they stop, they're intermittent, so you don't worry so much. You plan and do elective. But as I said, your priority depends on the seriousness.
Exactly.
Recent MI does not mean 2 weeks. It can be 1 month, it can be 2 months, it can be 3 months. If it's 2 months, I'm not bothered.
Yeah. Even, yeah.
Especially if it has, nowadays,
Yes.
especially if they
Yes.
put a stent in,
Yes, sir.
then I'm not bothered.
I mean, my cardiologist will tell me,
Once
you
they've
know,
had a
to
stent
scope the
placed,
patient.
patient is
Yes, sir.
asymptomatic, I can go in early.
Yes, sir. That's
Things have changed from the previous management of MI.
Yeah.
That's
Exactly.
also a big thing. So
Yeah.
I think,
yeah. Right. Second one is 21-year-old woman with 4-year history of intermittent diarrhea, severe lower cramping abdominal pain, is seen in the surgical clinic. On direct questioning, she admits to abdominal distension, a lot of bloating, gas, rectal dissatisfaction, that is sensation of incomplete evacuation, and passage of mucus PR, right? She is referred for colonoscopy. The surgeon is just pissed off. Just let's do a colonoscopy and get her out of the way. She's very anxious woman, typical, you know, young woman. Request a general anesthetic. How would you go about it?
First, we would assess that is it a functional disorder or not, because colonoscopy is a invasive test to start with. So first assess the hemoglobin level, is it falling with the diarrhea that she had for the last 4 years, and do some
so you
immediate
question whether we should do it or not. That's the question, right? Whether there's no weight loss here, there's no blood in stool, right?
There are no red flags.
Okay, fine. Yeah. Okay, happy with that? Oh, हाँ जी.
How many of you see such patients actually having colonoscopy?
Lots.
Almost every patient that comes to my clinic
Yes.
with this history has already had at least one, and 4-year history most likely 2 times. Sometimes by the same colonoscopist.
हाँ जी, फिर देख लेते हैं.
ठीक है?
The problem,
That's
yeah.
what I told you the other day. We raise questions about custom officers, about prime ministers, about corruption everywhere.
We are
This is corruption by
this
us.
corruption.
Whether it's me, whether it's anybody.
Right, exactly, right? तो इसमें अगर आप worried हैं and you want to do some screening test, जो कि आजकल what we do is we would do a fecal called protectin, which is non-invasive, and you do anti-TTG antibodies, which is for celiac disease screen. And that's it. इससे आगे आप नहीं करेंगे. पाकिस्तान में चूँकि incidence of colorectal cancer is very high in the younger population, you might, obviously you've got more experience in dealing with that, you might look at alarm symptoms. But इसमें जो है, especially if you are exposing her to the risk of a general anesthetic, for goodness sake, you wouldn't do that. Okay, good.
And one point, Bakar,
Yeah.
while you're on,
Yeah.
I'm sure you must have touched
Yeah.
it in the course.
Yeah.
The colonoscopy done under general anesthesia or under
Is
propofol
dangerous.
is more dangerous than without. Sedation, patient is screaming and you're increasing your loop, which is what usually causes perforation. So unless you're totally deaf and ignorant, you will stop and ask, "Bhai, kya hai? Masla nahi ho sakta." But if you don't have that, in general anesthesia, patient is not going to tell you or scream, and the loop can continue and you can perforate.
Or perforation, yeah, sorry.
So if you're doing it under general anesthesia or propofol, you become even more careful. If you don't understand, then if you lose 1-to-1, which they must have explained, I'm sorry, I have not been.
Yeah.
1-to-1 अगर miss हो रहा है या तुम्हारा scope जो है ना वो 90 or 100 centimeter पे you have a loop. No matter how straight, no matter what you're doing, you have a loop. Okay? So when you're doing GA, please be careful. Best not done, but if you're going to do it, sometimes you have to just be a little bit more careful. Sorry.
जो डॉक्टर साहब सिनारियो डिस्क्राइब कर रहे हैं, the type of perforation you get is terrible, क्योंकि उसमें या तो पूरा वो perf होता है, मतलब rip होता है, या the whole sigmoid mesocolon is ripped and you get massive hemorrhage from that. ठीक है, तो that is very important कि आप under GA only a very good colonoscopist should do it. This scenario, 58-year-old lady seen in clinic with a 5-kilogram weight loss. So you got an alarm symptom. Abdominal pain and recent onset of constipation. Recent change in bowel habit again is alarm symptoms, right? She has a history of stage 4 chronic kidney disease, CKD4, and she's referred for colonoscopy. What do you do? What are the issues here? Huh?
One is the CKD, we can't prepare the patient.
Huh?
So like colonoscopy, we have some limitation. The second is there is no family history involved over here. We need to look at her colon. But I would prefer first non-invasive if possible.
आप क्या करेंगे non-invasive?
We can do CT colonoscopy.
They won't do it the radiologist. वो कहीं contrast नहीं दे सकते क्योंकि CKD4 है.
Number one. Number two, a call point. You know why you want to do that is probably you want to avoid bowel prep. Because colonoscopy invasive way, I don't buy that. Done properly,
It's not
colonoscopy
invasive.
is as safe as anything else we
Yes,
do.
sir.
I tell my patients the risk of colonoscopy damage is less than you coming to my clinic. There is more risk of you
Getting run over.
run over by a car, hit by a car, or by a truck.
This.
But the point that he's making here is twofold. One, your bowel prep stops you thinking. So if you do CT colonoscopy, you need bowel prep.
You need water, and you
Number
need.
one, and it's not non-invasive. It's not a non-invasive procedure. They do put something through the back passage. They have to
Contrast.
dalna. And in a renal patient,
They
the
won't do
last thing you want to do is a CT scan. So all radiologists will
So
tell you not.
these are important issues. और इसको टरखा भी नहीं सकते. You have to do it. ठीक है?
So we discussed this day.
और वो danger जो डॉक्टर साहब कह रहे हैं, I was nearly got into that risk. क्योंकि सुबह मैंने करीम ऑर्डर की तो मेरा ख्याल नहीं था, तो उसने कहा योर कैप्टन विल कम इन 6 minutes. जब देखा तो उसकी डिस्क्रिप्शन थी, नंबर दिया था, एंड रेड सनबीम मोटरसाइकिल. मैंने वो So I didn't realize the vehicle जो आप ऑर्डर करते वो चेंज हो चुका था. मैंने कहीं गलत टच किया था. फिर उसको मैंने फ़ोन किया, मैंने कहा भाई बात ये है कि मैं मोटरसाइकिल पे नहीं, आप मोटरसाइकिल कहते हाँ जी मोटरसाइकिल है, बड़ी फर्स्ट क्लास है. मैंने कहा नहीं, मैं इस पर नहीं जाता, मैं दोबारा ऑर्डर कर दूँ. तो that would have been great fun. Anyway, so you use non-phosphate based, ठीक है, जैसे polyethylene glycol जो होते हैं ना, वो वाले आप यूज़ करेंगे. ठीक, that's the only issue basically. 67-year-old man with long-standing ulcerative colitis is on the surveillance program having colonoscopy every 2 years. 5 months ago, he underwent coronary artery stenting and is now taking clopidogrel. He is due for colonoscopy. How would you proceed? क्या? You don't have to stop it. Carry on. आपने कोई थेरेप्यूटिक प्रोसीजर थोड़ी करना है, वापसी देनी है, वापसी दें आप बेशक. ठीक है,
जब ऑफरिंग तो ले रहे हैं तो क्लोपिडोग्राफी का क्या है?
ठीक है. तो ऑलवेज बी क्लियर इन योर माइंड. ठीक है ना. तो अननेसेसरी लो रिस्क आप देखें, लो रिस्क प्रोसीजर है, आप डायग्नोस्टिक प्रोसीजर करें, वापसी ले रहे हैं, कंटिन्यू. हाई रिस्क हो, देन इट्स अ डिफरेंट इशू, देन यू हैव टू स्टॉप. ठीक.
What if he is taking dual antiplatelets?
क्या चीज़?
What if he is taking dual antiplatelets and we are going to do high risk procedure?
तो नहीं, तो हाई रिस्क में तो आप स्टॉप करेंगे ना. देखेंगे तो वो आपका वो है. हाँ, और मतलब आप ये अपने कार्डियोलॉजिस्ट के साथ फिर एल्यूट वो करेंगे ना. ऑब्वियसली जैसे उस दिन भी इनिशियल डे जब डिस्कशन था तो डॉक्टर साहब यही कह रहे थे कि एवरी टाइम आई डू इट आउट एंड दैट्स व्हाट वी नॉर्मली डू. वी ऑल डिस्कस.
Every patient who's had all this work
Huh.
has a cardiologist.
He has, and you have to ask
And
advice.
this is elective anyway. Emergency anything.
I'm asking because in CPSP scenarios they ask gastroenterologist, what would you do?
No, but that's fine. In that, I would always write that, end of the day, I would always discuss. And when I was assessing, and I've only done it a couple of times, after which I was never called, because I wrote in the key
Yeah.
that the answer of the candidate is better than the key provided. So he should be given more marks than whatever the key said. Because
Yes.
he had given such a wonderful answer
Acha.
using guidelines, but there was no way for me to give him more marks. And the key was not correct. So I wrote that, and most people probably don't. So that's what that was the last time I was invited. But what I'm saying is that आपके पास उस आंसर जो आप लिख रहे हो ना, उसमें कोई वहीद नहीं है कि कोई ढंग का की बनाने वाले ने उसमें एक पॉइंट ये डाला हो कि डिस्कस विद का. Today in this day and age, you have specialists. What for? Number one, number two, एक बात बताएं वकार इसमें जो the newer anticoagulants.
Direct acting antibiotic. Let me get in picks up.
What is the recommendation for those?
72
How many
hours.
days?
72 hours.
3 days.
3 days. लेकिन चक्कर ये है ना कि लोग ये इसलिए देते हैं कि चलो जिसमें मॉनिटरिंग नहीं है. I don't think it is any safer. If in fact it is more dangerous than giving warfarin. Personally, that's how I feel about it. क्योंकि उसकी ना मॉनिटरिंग आप कर सकते हैं ना उसका एंटीडोट है. अच्छा दूसरा ये केस 82-year-old लेडी अंडरगोज कोलोनोस्कोपी फॉर आयरन डेफिशिएंसी एनीमिया. अब आयरन डेफिशिएंसी एनीमिया ऐसी चीज़ है कि इसमें आप करते हैं कोलोनोस्कोपी, ये इन्वेस्टिगेट करते हैं क्योंकि इन व्यू फॉर एज एंड फ्रेलिटी शी वाज एडमिटेड फॉर बाउल प्रेप. ठीक है, these are all real cases. The procedure is prolonged and difficult because of severe diverticular disease. It is very common there. यहाँ पे आप लकी हैं. यूके में diverticular disease बहुत common है, especially जिस औरत की diverticular disease भी और previous hysterectomy भी हो. They are a nightmare. So and she had very poor bowel cleansing. ठीक है, so that is again an important factor to note. 5 millimeter polyp is removed from the transverse colon by hot biopsy. Another important factor. You are called to the recovery area because she is complaining of severe generalized abdominal pain. How do you proceed? इसमें issues identify करें. एक तो खैर the indication was correct. ठीक है? She is frail. Another comorbid factor है. Admitted for bowel prep. हमेशा याद रखें कि हॉस्पिटल के अंदर इन हॉस्पिटल बाउल प्रेप जब भी होता है इट्स नॉट गुड. चाहे ये पाकिस्तान में हो, चाहे वलायत में हो, चाहे अमेरिका में हो. Everywhere I have seen it. And I'm sure that might be your experience as well. Okay. So procedure is prolonged and difficult because of poor severe diverticular disease and very poor bowel cleansing. Poor bowel cleansing is always a bad risk factor, and ideally one should not proceed if one is not safe or confident. Aksar, I would have.
It's also a reason for perforation.
Exactly. And if it perforates, it is more complicated because of peritoneal soiling with feet. 5 millimeter polyp again is important, and transverse colon by hot biopsy. इसमें क्या क्या आप मतलब what is the discussion point है? क्या क्या गलत है?
Risk factors are the prolonged procedure, diverticular disease.
हाँ.
So prolonged procedure, okay. Stop
ठीक है.
there. Prolonged procedure, why?
Longer procedure, more manipulation.
No, why has she got prolonged procedure? What is the reason?
Because of poor visibility.
Because of the bad bowel
Bowel
prep.
prep बिल्कुल.
Diverticular disease doesn't really prolong the procedure that much.
लेकिन
But if
bowel
you
prep.
had bad bowel prep with
It makes it
severe diverticular disease, you wouldn't know where the hole is. So bad bowel prep here is number one enemy. है ना?
हाँ,
Number two पे आ जाए. So you've gone and done a colonoscopy with bad bowel prep in a bad diverticular disease. That's bad news.
Bad.
Second, polyp, 5 mm polyp, removed by where
Two.
was it?
Transverse colon. ठीक है?
So you see, one after the other, all wrong.
All wrong.
If you had to take it out, 5 mm polyp, cold snail.
Secondly, would you remove the 5 millimeter polyp? I probably wouldn't.
नहीं, and दूसरा एक
हाँ.
और भी है. If you remove a
हाँ.
5 mm polyp with such bad bowel prep, how will you recover it?
हाँ.
और recover नहीं किया polyp को, तो I am sorry, what bad, 5 mm polyp को निकाल के तो फायदा रहता है.
अच्छा इसका मतलब एज देखें माई का 82-year-old है. 5 millimeter polyp जब कैंसर में बनेगा तो it will take 10 to 12 years. By the time she becomes 92, अगर उसका कैंसर बन भी जाए उसका ऑपरेशन तो वैसे भी नहीं होना. She is bed bound.
अभी तो उसकी बैंड बच गई.
वही ना. तो इसमें नंबर वन whether the polyp should have been taken out or not, I wouldn't bother. मैं तो अक्सर करते ही नहीं ऐसे उसको. Secondly, hot biopsy forceps हमारे अस्पताल में ज़्यादातर इंग्लैंड में it is banned. Nobody uses it.
I think the only place where you can actually make a case for hot biopsy forceps, in my opinion, is rectal.
हाँ ठीक है
That
ना.
also be careful. Because there is no role.
एग्जैक्टली
अगर 5 mm का पॉलिप है उसको निकालना है तो बायोप्सी फोर्सेप्स से निकाल लो। अगर
कोल्ड
इसको
कोल्ड बायोप्सी
कोल्ड बायोप्सी
मिक्स
फोर्सेप्स वरना कोल्ड स्नेल छोटा वाला डाल के निकाल लो बगैर में। I don't use for 5 mm
हाँ
wherever they are.
हाँ
I don't use hot snare anyway.
अच्छा
I
हॉट
just use a cold snare.
हाँ हॉट बायोप्सी फोर्सेप्स में मसला ये होता है कि आप जब उसको पकड़ लेते हैं तो लोग जब उसको प्रेस करते हैं वो उसका जो एंडो कट का they keep pressing it down till actually the whole thing becomes brown. That shouldn't happen. Hot biopsy force में जब आप पकड़ लेते हैं तो आप जो ही उसको प्रेस करते हैं पेडल को तो when you see it blanching जब वाइट हो जाए ना उसी वक्त आप बायोप्सी फिर निकाल लें क्योंकि जब वाइट होता है तो आप उसका ब्लड सप्लाई कट कर देते हैं तो it shouldn't be used at all हमारे अस्पताल में तो यूज नहीं होती तो इसमें ये 2-3 चीज़ें जो है ना they are worth noting ना ठीक है
So
that's
let's go on with this. How do you proceed? If you have a patient who
हाँ,
does
exactly.
colonoscopy and they have abdominal pain, like she has, and you find this history.
So how do you proceed?
What would be your next step?
ठीक
I immediately want the surgical things. I would immediately want the surgical things. Secure IV access, IV fluids, IV
Yeah, you need to start the standard
Exactly.
resuscitation.
absolutely
Get the surgical team. Don't hide. You know what our general, the reason why I continued with this problem is आपकी colonoscopy या perforation हो गई अब पब्लिक को पता चलेगा फिर क्या होगा सो यार इसको छुपा दो एंटीबायोटिक दो देखो आई वी डोजेस आई वी वो डोंट डू दैट perforation हो गई I mean you know complications do occur
Recognize
if it has
complications.
been done because you did something wrong there is learning for you inshallah next time you will never do that again but इसको छुपाना नहीं है don't put it under the carpet कि उसमें पेशेंट को नुकसान पहुंचे get the surgeon I agree get the surgeon involved get the
डिस्ट्रीब्यूट कर
surgeon
दें
whatever
खाना डिस्ट्रीब्यूट कर दें कर दें हाँ कर दें उधर चिप्स की खुशबू आ रही है उधर
ऐसे पेशेंट को you must not वो पेन सेटल हो गया आपने कहा ट्रेमोल दे दो गैस वैस बढ़ गई यार थोड़ा ये आपने कहा ठीक है पेशेंट का पेन थोड़ी देर के लिए ट्रेमोल से ठीक हो गया आपने घर जाओ कर दिस पेशेंट you must not send with all the things that have been mentioned you must not send her home keep her for observation at least 24 hours if she completely settles abdomen is soft there is nothing at all send her home next week
next patient I think around the class a 47-year-old man underwent colonoscopy and smear polycarbonate of 18 millimeter sessile lesion, which is obviously high risk, from transverse colon. There was some bleeding at the time of polypectomy, controlled by placement of 3 endoscopic clips, which is fair enough. His wife telephoned the endoscopy unit 3 days later to say that he is experiencing a great deal of abdominal pain. You are asked to advise. How do you proceed? Phone किया उसने घर से, क्या करेंगे उसको? हॉट वाटर बॉटल लगा दें पेट के साथ के गर्म वो टकोर पड़ेगा तो ठीक हो जाएगा call him back because basically you are suspecting it might be post polypectomy syndrome जो बाद वक्त होता है ना full thickness burn हो जाता है it might not be a full perforation but it might be that or it can be a perforation क्योंकि जब उसको bleeding हो रही थी क्लिप लगा रहे थे उनने हो सकता है ज़्यादा कॉटरी यूज़ की हो उसको वो करने के लिए तो he might have done a full thickness burn or a perforation. So call him back, always. Play safe. Discuss the safety of colonoscopy in pregnancy, cardiac pacemaker with an implanted cardiac defibrillator after colonoscopy. ये चीज़ें मतलब issues आती हैं आपके clinical scenarios में. तो with a cardiac pacemaker हमेशा चक्कर होता है उसका diathermy का. अगर if it is a normal cardiac pacemaker, आप you carry on this short bursts of diathermy current, उससे कुछ नहीं होता. अगर उसमें implantable defibrillator होता है, then you ask your cardiac technicians to put a magnet on the cardiac device. उसको defibrillator को आप inactivate करते हो, वरना जो ही आप करंट इधर दबाओगे तो उसको शॉर्ट मिलेगा, वो उधर ही.
This scenario happens quite often with ERCPs.
हाँ, exactly.
So again, my view is simple. I'll get the cardiologist involved, find out, I don't want to know and I don't remember anything about pacemakers. I don't even know what type of pacemakers there are, neither do I want to.
No.
Okay? So I will ask them, कि भाई मुझे ये करना है. Now, so the tech comes, he does whatever he has to, gives me permission to go and use my elective surgical unit, and then we go ahead and do it. So the responsibility is not on me. Okay? Because, like Waqas said, why should I get involved in what pacemaker
मुझे आता नहीं है उसके बाद में कुछ
साला कुछ गड़बड़ हो जाए तो आपकी मुसीबत।
नहीं exactly
How do we know? It's best done by the
specialist.
And the permanent pacemaker में सर ये नहीं करते?
क्या मैं तो करता हूँ।
नहीं आप पूछेंगे
टेम्पररी तो काम नहीं करेगा।
टेम्पररी तो काम
पर परमानेंट पेसमेकर हो, आपका डीफिब लगाओ, कुछ भी हो,
आप उनको बुलाएंगे।
कार्डियोलॉजिस्ट
You have to ask them.
उससे बोलो आगे
हाँ
भाई हमारा
हाँ भाई हम क्योंकि नए नए पेसमेकर्स आते हैं आपको पता नहीं कि क्या होगा वही ना तो you have to ask them. हाँ तो as long as you ask them that's fine. प्रेगनेंसी में अव्वल तो यह है कि प्रेगनेंसी में कोलोनोस्कोपी का ये है कि इतनी कोई अगर प्रेसिंग यूजुअली दे आर फिट पीपल प्रेसिंग नीड नहीं होती अगर दे कम विद सिवियर अल्सरेटिव कोलाइटिस all you need to do is a rigid or a flexible sigmoidoscopy to make a diagnosis and treat them. ठीक है अगर कोई और होगा उसको चीज़ें तो ask them wait you can wait unless that patient is bleeding actively and exsanguinating फिर आप pregnancy किसी की परवाह नहीं करते आप colonoscopy and treat. Okay. After colonic anastomosis again you have to be careful अगर recent हो तो अव्वल तो यह कि immediately after surgery it's contraindicated अगर recent हो उसने surgeon insist करे कि आप check करें मेरे लिए तो it has to be done by an experienced colonoscopist who uses very little air insufflation क्योंकि a lot of things can happen with barotrauma. air जब आप डालते हैं ना तो अक्सर ये बाद वक्त mucosal lesions आते हैं ऐसे वो से bleeding भी हो सकती है ना तो you have to be careful.
Is there any cutoff value recent? How recent? Is there a
6
No.
months, if I remember correctly, this is 6 months.
What?
recent colonic
That the recent
anastomosis
one.
that
No,
you can
6
go
months.
नहीं नहीं 6 months नहीं है
Everything is healed by 2 weeks.
2 weeks तो 3 हफ्ते में
2-3 हफ्ते।
देखें ये सब चीज़ें जो होती है ना
He's talking about immediately after.
immediately after ना ये सब चीज़ें आप करते हैं in liaison with your surgical colleague आप वैसे नहीं करते ना you obviously would be
आप
asking
ये सोचो ना,
हाँ।
why is he asking you to do
हाँ।
an anastomosis?
वैसे तो
Either it's closed
हाँ
or it's leaking
हाँ
It's bleeding.
or it's bleeding.
bleeding
ये
तो-
तीन ही reasons हैं
ये
ना।
तो-
तीनों reasons में जिसमें जो 2 reasons हैं leakage and
हाँ।
bleeding वो again I told you before अगर आप नए मकान ने कहा था कि आपकी ये चीज़ बाकी चीज़ों के को वो कर देती है.
हाँ।
So you go in but like he said that you try not to influence. Especially if it's obstruction because what will happen is your air is going to make the proximal section even more dilated and the patient will balloon up.
You can't go there. and
So you have to, when you're doing it in an obstructed person, you try not to put your finger on air. So you're just trying to do colonoscopy without proper view,
बाकी
which is possible
एक-
because usually distal and
वॉल्वुलस में आप करते हैं therapeutic colonoscopy to decompress it ना लेकिन that again has to be an experienced colonoscopist.
Is there any guidelines, sir, especially in the patients of the surgical type of the patient who have already undergone any type of the anastomosis? So, for the definition of the anatomy, the NEMA studies होनी चाहिए उससे पहले कि नहीं होनी
नहीं any marker कोई नहीं करता
अब कोई नहीं करता अगर
What
सर्जिकल
kind of anastomosis they have done? What's the anatomy inside?
नो नो
not anymore.
no any कोई नहीं करता
Not anymore. I mean, very minimum.
Without-
Really, I only do now for patients who are very severely, young patients who are severely constipated, just to look at if they have
Very long
distal,
colon, redundant colon,
adults Hirschsprung type
हाँ.
of कोई चीज़ है because he's not be able to pick it up otherwise. But not
No,
otherwise.
no,
I can't
no.
remember why I would do a barium
no severe colitis में colonoscopy is contraindicated ठीक है अगर आप किसी को rectal bleeding के लिए कर भी रहे हैं colonoscopy आपने बुक किया है consent किया है but if you find you've got severe fulminant colitis stop take biopsy make a diagnosis come out जब सब कुछ हाँ सॉरी हाँ जब सब कुछ सेटल हो जाए at a later stage you can do a colonoscopy to determine the extent of the disease sorry
If you have severe colitis, go into the rectum, take biopsies. People go in and come out because they're scared to take biopsies. Rectal biopsies
उससे
are
कुछ नहीं होता।
safe. Okay? You're only taking mucosal. There's no point putting your scope coming out without taking biopsy.
Especially
You
lower
don't have
rectum
to
में
go in too much. Like he said, rectum में जाना is enough. you'll see that it's bad. Take biopsies, come out, you don't need to know what the extent is now. And like he said, when the patient settles, make sure you write that this patient needs a colonoscopy to no extent. One point I must add here, most patients that come to see me with colitis have not been told by their doctors their extent. It was our practice there, and I'm sure they still do it, I still do it here. I sit down and tell my patient we have colitis up to here. And it's important because after 10 years we will be looking at, and also because there are topical treatments and non-topical treatments. So if you have extensive disease, there is no point. And when you come and see me, I need to know if it's distal disease, I want to see what topical treatments have been tried. So it's a good practice. Once you have a colitis patient, tell the patient what their extent is. So if they go and see someone else, acute diverticulitis.
Again, if you find acute diverticulitis, there's pus, blood coming out of divertically, abandon. Don't mess around. Otherwise you cause a problem.
Thank you, sir.
ठीक है जी?
इसको छुड़ा दें।
बस ये हो गया सब हो गया.
This we can do after the lunch break.
हाँ बस हो गया. All done.
All done.
खलास.
Okay,
अब मैकडॉनल्ड खाओ भाई.
start